Stellarex in the real world, interim results from the SAVER registry. Here's my disclosures. Here's an overview of the Stellarex clinical program, again, which is fairly robust. And again, at the bottom is the one that we'll be talking about the most, is the SAVER e-Registry. Looking at both the femoral popliteal area and the cohort. The second cohort is infrapopliteal. So the Stellarex Vascular e-Registry, again, a multi-center European study with the Imaging Core Lab looking at the cohorts of CTO, ISR, long lesions, and calcification. Finally, there's obviously the external monitoring and the clinical event committee adjudication, and then patient follow-up at 3 years. And you can see the criteria on the right. Again, it's fairly robust in the wide range of patients that are being looked at. So the overview for the eligibility criteria is you have symptomatic patients with stenosis of the S or popliteal intended to be treated with PTA using Stellarex over the wire DCB. They can either be de novo or restenotic, and looked at Rutherford class 2 and 3 disease, and then 4 and 6 were added later. And again, not 100% sure about the Rutherford class 2. As a vascular surgeon, we don't see that very much, nor treat it very much, but again, included nonetheless. So for cohort 1, safety looking at freedom from 30-day device and procedure-related death, and freedom from 12-month target limb major amputation, and clinically driven TLR. And then finally, efficacy is looking at freedom from 12-month clinically driven TLR. And finally, in cohort 2, you have those patients with CLI, and it's looking at freedom from composite adverse events, as well as perioperative death through 30 days. And then finally, the efficacy group is freedom from clinically driven TLR at 6 months post-procedure. So looking at the device itself, again, you've seen, they've discussed the pharmacokinetics before, but looking at a low dose of paclitaxel that's given. It's a hybrid crystalline formation, and it's effective drug tissue transfer and residency for greater than 28 days based on studies. And then again, one of the more important things is there's a limited amount of drug loss in particular that goes to the distal portion of the lower extremity. So the Stellarex Vascular e-Registry, the interim analysis of 500 subjects is as follows. So it's continued to assess the treatment by Stellarex DCB in superficial femoral, popliteal, and infrapopliteal arteries in a broad real-world claudicant or critical limb ischemia patient population. And again, similar overview with the 45 centers in the core lab with external monitoring, as well as the clinical event committee adjudication, and 3-year follow-up, as well as all above-the-knee patients enrolled up to this point in the study. So in that cohort 1, you have 502 patients with a total of 587 lesions, and 397 with follow-up of at least 12 months. So baseline characteristics, again, fairly similar, though there are some differences. It seems like my patients have far more type 2 diabetes. Hypertension is relatively similar. Almost all of them smoke as well. And then renal insufficiency. It seems like our cohort in the U.S., at least my patients, have a significantly higher incidence of renal insufficiency. Baseline characteristics, again, these are not your classic very short lesions that are easy. There are some challenging heavily calcified lesions. About 1/5 of those are heavily calcified, and about 1/5 of those lesions are also long, greater than 150 millimeters. The procedural characteristics, again, predilation was done in 68% of the patients. And the number of balloons used is roughly 68% for 1, and then greater than 3 is roughly 15%. Finally, post-DCB stent placement. Again, this is fairly consistent. About 1 in 4 will ultimately need scaffolding. Post-procedural final stenosis, roughly 8%. Lesional success is almost 99%, and then procedural success, again, is 98%. So the primary safety endpoint, again, freedom from device and procedure-related death through 30 days post-procedure, and freedom from target limb major amputation, and clinically driven TLR through 12 months post-procedure is almost 89%. Procedural complications are fairly low. At 1%, there were no deaths, no strokes, MI, and then you only had 1 subject that ended up needing emergency surgery to correct a complication. Embolization was also fairly low, 5 out of 586 patients. And then target vessel thrombosis happened in one of those 586 patients. So that primary efficacy endpoint, again, freedom from clinically driven TLR at 1 year, again, at roughly 90%, again, at 1 year. And then the key 1-year clinical secondary endpoints, again, all-cause death, roughly 2.5%, cardiovascular death at 1.5%, and then finally amputations at 1%. And then major amputation being 2 out of the 403 patients that were part of the study. Finally, the efficacy endpoints, TLR 11.4%, clinically driven TLR, again, 11%, and target vessel revascularization of roughly 0.5%, and then clinically driven TVR is the same at 0.5%. So some additional secondary outcomes, again, looking at 12 months, the ABI is obviously significant, going from 0.7 to 0.9. The significance of that, again, can vary without waveforms being apparent. But probably the more intriguing thing is this, the walking improvement, that questionnaire. Patients generally had a significant improvement in their walking distance and their quality of life when it came to ambulation, which I think is the whole idea that we're treating patients that don't have critical ischemia, that are just claudicants. So SAVER registry conclusions, again, the interim analysis of the SAVER registry confirms that the devices overall at 12 months is safe, with cardiovascular-related and major amputation rates around 1% and no procedure or device-related deaths. Procedural complications were low, and with distal embolization and thrombosis rates at 1% respectively. And Stellarex demonstrated a 12-month all-cause mortality of 2.5% and a clinically driven TLR of roughly 11%. 88% of patients had improved Rutherford category with correlated improvements of quality of life scales at 12 months, and then a reinforced safety profile and effectiveness for Stellarex in a real-world patient population. All right. Thank you very much.